Well, good afternoon. We're going to go ahead and get started. I'm really delighted to welcome you here today to this year's Lutzker Lecture. The lecture series is funded by an anonymous donor in honor of Dr. John R. Lutzker, Distinguished Professor Emeritus. Dr. Lutzker was former and founding director of the Mark Chaffin Centers for Healthy Development here in the School of Public Health at Georgia State University. His contributions to the school have been really invaluable. Through grants and contracts, Dr. Lutzker really did a lot to elevate the Mark Chaffin Center to a university research center here at Georgia State. The Mark Chaffin Centers for Healthy Development comprise a university-level research center focused on public health research solutions that prevent child maltreatment, reduce sexual and family violence, optimize life course social emotional health and development, and promote inclusion and quality of life for individuals with intellectual and developmental disabilities. Dr. Lutzker dedicated his academic career to advancing scholarship in service of preventing child neglect. He is an internationally recognized expert in the field of child maltreatment. He's responsible for developing one of the few evidence-based child maltreatment and neglect prevention programs called Safe Care, implemented throughout the U.S. and internationally. The Lutzker Lecture Series allows the School of Public Health to host an eminent scholar on public health topics. And to introduce this year's speaker, please welcome Dr. Kathleen Baguette, Director of the Mark Chaffin Centers for Healthy Development.
Good afternoon. It is my pleasure to introduce this year's John R. Lutzker Lecture featured speaker, Dr. Shannon Dorsey. Dr. Dorsey is a tenured professor and associate chair for graduate studies in the Department of Psychology at the University of Washington. She completed her PhD in clinical psychology at the University of Georgia, followed by a postdoctoral fellowship at Duke University. She has 122 publications, and she's received numerous awards for her work, the most recent of which is a career award, which is from the Implementation and Dissemination Science Special Interest Group of the Association for Behavioral and Cognitive Therapies. And this was for her work on task sharing for implementing evidence-based interventions for children and adolescents, domestically and internationally. She's conducted extensive work on trauma-focused cognitive behavioral therapy, and she has implemented hybrid research designs that include both effectiveness and implementation questions. She has an illustrious funded research portfolio and is currently engaged in 8 active projects. She leads 2 NIH projects and then serves as a mentor or investigator on the others. She's currently examining the role of supervisors in public health, mental health settings in supporting evidence-based practices, and she's conducting work in Tanzania and Kenya, implementing a randomized controlled trial of trauma-focused CBT using task shifting with lay counselors with little or no experience in mental health training to deliver group-based trauma-focused cognitive behavioral interventions with children and adolescents who've lost a parent. She is also working with colleagues at Johns Hopkins Bloomberg School of Health, and she's involved in a randomized controlled trial and feasibility studies in southern and northern Iraq, the Thailand-Burma border, and Colombia and Zambia and Ethiopia. In sum, she's a phenomenal clinical scientist, an amazing mentor, and the title of Shannon's presentation today is Extending Mental Health Service Research, Task Sharing, and Community Partnerships. Please welcome Dr. Shannon Dorsey.
So this is a pretty fun talk for me. I'm from Georgia. I'm from Albany, Georgia, if you've been to Southwest Georgia, Saliga. Here I am also the other Shannon because of Shannon Self-Brown. We have a few Shannons, but sometimes she's the other and sometimes I'm the other, and today I'm the other. And it's just fun to be right down the road from where I got my PhD. And it's fun to not be the only one in the room with a Southern accent, which often happens to me in Washington State. It actually gets me pretty far, I think, in terms of people thinking you're going to be kind of laid back and maybe down home or something. So it tends to work for me, but I'll probably get more Southern as I've been talking to folks who talk Southern today. So I'm really excited to be with you and talk about some of this work. I'll be in and out of the light. I have light-induced migraine sometimes, so I'm saying I'll stay in the light a little bit, but then I'm going to step over here and make sure I don't, end up with a bad headache by the end of the day. So my focus has been on implementation science, and I'm going to be talking about implementation science today. Part of what I care about, the values that drive my work and what I'm interested in, and the research question that underlies everything that I do, or the goal, I would say, not even the research question, but is how do we get what works to the people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. There's lots of definitions of implementation science. I think I like our UW Department of Global Health definition the best because I think it puts people at the center of it, not the methods. This matters. In the picture I just showed you is from Moshi, Tanzania, where some of my work has been. This also matters. This is Garfield High School down the road from my house, where my kid will go to high school and is one of the most diverse public high schools in the state of Washington. It's a fabulous school. But it also matters there because even in places like Seattle, not everybody gets quality care that will help them address their needs and issues. This is a picture of Seattle, as you can tell. It is as gorgeous as you imagine. I love it a lot. You might wonder, since I'm going to talk about some global work, what is the coverage for minimally adequate care, for example, for depression? Depression is not my area, but Graham Thornycroft did this study looking at minimally adequate care, and I think it gives some nice statistics. So folks that get minimally adequate care for depression in low and middle income countries is about 1 in 27. That might not surprise you if you know much about global health, and especially about global mental health, where there are fewer dedicated resources. But it is not great in high income countries either. America has a lot of resources, and 1 in 5 people get not just care, minimally adequate care. So not high quality care, but minimally adequate care is 1 in 5. So there are a lot of places we need to be focusing on our interventions, how we implement them, and getting them out there. And as a School of Public Health, none of this is a surprise to you. The interesting thing about kids and adolescents, if you don't focus on this population, is that especially in global settings where a lot of my work is, and I'm going to focus on that mostly today because I'm going to talk about task sharing, and I'll define that in just a moment, but it's even harder for kids and adolescents. So in low and middle income countries, about 2% of the health budget is on mental health. Most of that, of the health budget, not the national budget, and most of that is for serious mental illness, most of it's for adults, but kids make up about 50% of most populations. And so kids, in particular, don't necessarily have systems or resources tasked with providing their mental health care, which makes understanding implementation of mental health care even more important because there's not a natural system we would go to. So UW has lots of implementation resources. You have lots of expertise at Georgia State too, but I wanted to put our landing page for implementation science at UW here because they make this really clear point. Why does implementation science matter? It matters because interventions and evidence-based practices that are poorly implemented or not implemented at all, which is often the case too, even though we do trainings and support, they don't produce the health benefits that we want. So we have to really be thinking about not just our interventions, but also how they're implemented. And they go more hand in hand than we ever think. Some of our early studies of interventions, when they went back and looked at the fidelity, they didn't actually get what was designed to be tested because people didn't necessarily deliver it with fidelity so that you could say kid A actually got intervention B. So our interventions and how we implement them are really connected if we want to get the outcomes that we want. So when I talk about task sharing today, which is an implementation strategy, I'm going to be talking a lot about both the intervention and the implementation. So I really like non-jargon, plain language things. And for any of you who work with community partners, which is probably everybody in the room, you do not get good work done if you do not have a common language to talk about things. And fields of science love to make up complicated language and our own jargon that we can own and really feel like, yes, I know something. I've had battles with some of my colleagues about this, and the thing we came to is within a field of discipline, if I'm talking to other implementation scientists, it probably is efficient for us to have a common language that might be jargon just because it helps us communicate together. But to connect with folks who are outside the field And outside that little discipline, you really need some non-jargon terms. And so Jeff Curran at Arkansas has done some amazing work with these implementation terms made simple. And so I'm going to use this to structure the talk today, but I use it with my partners, but I also use it with NIH project officers. I also use it with folks that I want to be sure I can convey, why do we care? See, in Washington, when I say why, and it's multiple syllables, nobody really understands that, but here probably that doesn't, strike you as that odd. So that's kind of fun to be able to extend my one-syllable words to 2 syllables. And if you can't communicate to funders and folks in other fields why it actually matters that you look at implementation, then you don't get very far. So, I've used these terms not only with partners, but NIH project officers to make a case for the implementation focus of our work. So I'll be walking through this today. So, and I'll come back to each of those terms. So within implementation science, like in any field, there's models and frameworks and measures and theory, and I do believe in theory. I'm not going to say I don't believe in theory, but my focus has really been on practical implementation science. And when I read this op-ed, this editorial, and saw what Westerlund had to say, I said, this is me. This is what I want to do. This is what I'm interested in, is practical implementation science. Because a person who wants to find a solution to a public health problem has a different task than someone who wants to create or test a theory. And when you put your partners first, they usually want a practical solution to a problem and are probably less interested in contributing knowledge to a theory, though that can happen over time. But right now, you need a solution so the kids in your organization can get high quality care. The way that I have addressed this is really looking for low or lower cost interventions, very much the public health approach, and also how in every community that I work in can I be working towards those community members being the supervisors, the leaders, the trainers, that they take all that on and I get to keep stepping back. I get to share knowledge, but then I don't have a leadership role, they have the leadership role. And then we've been evaluating the effectiveness of that so that more people can do those kinds of things and support it. So the first term, intervention, practice, or innovation, as I think is what we typically think about. We're usually trying to implement something. And the simplified Jeff Curran term is the thing. So what is the thing that we want, that we focus on, that we want to be done, that we think will make a health impact, but that may need support to happen? So since I'm focusing on task sharing, I'm going to talk mostly about some of the global work. And you may or may not know this for mental health treatment, but there's a huge inequality in availability of mental health treatment globally. So there's a significant mental health treatment gap where over 75% of adults with mental health need do not receive care. There's scarcity, so there's few mental health professionals who can provide that care. And then there's inequity within and across countries. So I work a lot in Kenya. You'll have more providers in Nairobi than you would in Homa Bay or other rural areas. And we know that for kids, probably not surprising to you, it's a lot worse. So for kids, fewer than 1% of kids with need receive any treatment because, again, there's no active system to support kids, and serious mental illness, understandably, is going to get more of that money and maybe adult depression. There's a big need to find solutions to deliver mental health care for children and adolescents in low and middle income countries. And because there aren't many mental health professionals in low and middle income countries, we don't have enough mental health professionals in the US either, nor honestly do we need them to deliver high quality care, which is the punchline of kind of my entire talk if you need to leave now and get chapstick on the way out, because I was like, oh, they got Georgia State chapstick. This is very cool. So I'm going to get some. So it's not going to be mental health professionals. If we try to concentrate there, even in the US, we're probably not going to get very far because it's a capacity issue and there's gatekeeping for some of the professional degrees. So it's not going to be mental health professionals. So in other fields of health, people have done a ton of work on task sharing, OBGYN, training folks. So you're either shifting the task to a non-professional where it's not a nurse or a doctor, but someone you've trained. Sometimes doctors' work is task shifted to nurses. In mental health, what we're doing is task shifting the work of a mental health professional to someone who has little or no training in mental health. So they may have had a little bit, they may have had some experience, but they don't have, say, a master's in social work, or they don't have, a master's in psychology. And these are the folks that are going to meet the mental health need. And again, the punchline is they can do really, really well. I think in some ways it's our professional disciplines that want to gatekeep and hold things to ourselves. There's a lot more room, though, in other places where we don't have as many mental health professionals, though, because there's such a great need. So I'll be talking about the task shifting or task sharing. Most of my projects have been shifting because one of the regions I work in that I'll talk about, Bungoma, Kenya, which is on Western Kenya, near the border of Uganda, the psychiatrists we needed to rely on, there was one psychiatrist that we needed to have a contact for serious mental illness. He was 2 hours away and then he retired and we weren't sure who our connecting point was nearby. So sharing would be you're doing more of it together, and shifting, meaning you're kind of passing it to the lay providers, who of course are supported and trained, which I'll talk about, but you're shifting the care to people who have the capacity to do it. So, if you're training lay providers, this is one of my grads, Prerna Martin, who's now at the University of Oregon, a training we did in the autonomous region of Bougainville. If you're going to train lay counselors, I don't know if you know training in the U.S. for mental health professionals, but typically it's about a 2 or 3 day training. That probably isn't enough for us to really change our behavior, because it's really hard to change behavior, but that's all a mental health professional can do, and we know people are licensed and have their graduate work. For lay counselors, we try to hire folks who are really good with people, who have some child or adolescent experience, who have some mental health sometimes experience. They've worked with an NGO or another project, but they just don't have the degree. We do a 2-week training, and it's very behavioral rehearsal focused, which means practice. And I've written that if you're interested in behavioral rehearsal as a training tool or a way to assess quality of care, we've written a lot about that with a colleague of mine, Renad Beta, so there are a few papers out there you can check out. But we basically spend very little time teaching. We don't have PowerPoints. You see Prerna there, sorry, the picture is kind of dark because we didn't have lights. We were doing a training in a small village and we didn't have lights. But you basically are doing just a very little bit of training like she's doing in front, maybe 30 minutes to teach a skill, but then the rest of it is trainee practice with their peer and expert feedback. So within that small group, you're building everybody's ability to be like, oh, are we doing it like is on the sheet? Is there a way we could do this better? And then there's a lot of time practicing before you deliver, because you haven't delivered care before. So you do the training with us, then you go back with someone in the group who we've identified as really skilled, who's going to lead a small group of folks in continuing that practice before you deliver to a human. Because we do think lay counselors are a solution, but we don't want them working with individuals before they're ready to do well and not do any harm. So there's more practice built in. And then they tend to have a weekly supervision call with a treatment expert. In the very beginning of my work, this was me. Now it's never me. Now it's always an experienced lay counselor or trainer who's taken on the leadership in their community, their country, their region. So when I say treatment expert, I don't mean with a PhD behind their name. I mean someone who has expertise in the treatment, and that could be a lay person or that could be a mental health professional, depending on where you're starting. So this is just one of the examples of just a role play, just very small group. The paper right here in her hand, that just has like some small written steps. We don't have long manuals. We have like a step sheet that you just kind of walk through the steps. We're doing a role play and a practice, and I'm just giving some feedback. We do a lot of experiential work. This should be part of our US-based trainings too. We know just lecture doesn't work. It really needs to be experiential and active. And so here, these are colleagues of mine in Tanzania at the very beginning of our work in 2009. Now we all have many kids and lots of other connections. Many years later, very young when we were doing this work. But we did an activity where I just drew 5 different kids and what maybe they were dealing with. And I had skills written down from the intervention I was teaching, which was trauma-focused CBT. And they would pick which one went with the kid and practice it out and make a plan. And here they're practicing doing a cognitive triangle. So, it's a 2-week training, but it's not lecture. You're really practicing the job that you're going to do. And then we're also trying to use games, because think about a 2-week training, that is a long time. So we're also trying to use games. So one of the things that we do, this is Simon from the past picture. This is a project in Zambia. So Simon came from Tanzania with me to Zambia to do some training there and to do some cross-cultural sharing across these different projects. And what we did here is designed an activity where people were practicing cognitive restructuring. And it's very hard to ask in cognitive behavioral therapy. You're trained to ask these really open-ended questions. But they're hard to construct, even when you have a PhD or a master's. This is probably what people struggle with the most. So we made up a game that if you asked an open-ended question, that was teaching somebody to fish, so everybody would hold up the fishing rod. And if you actually just told somebody an answer, so it's like a closed-end question, you'd hold up the fish head. And of course, we were using this saying, like, give someone a fish they can eat for a day, but teach someone to fish they can eat for a lifetime. So we come up with a lot of games to make it a little more active and fun, given that it's 2 weeks, which also would be good in the US because adult learning suggests we don't like to sit and listen. So, I think the lessons are all pretty, apply a lot of different ways, but we have 2 weeks to do it, so we have a lot more time to have fun. So across a bunch of projects, Manus, Thinking Healthy, IPT, the right one was India, the middle one is Pakistan, and then the last one, Manus, IPT, that was in Uganda. All 3 of these projects describe that we can deliver a lot of the evidence-based practices and train lay providers to do these. We do need to think about how training is conducted, like the 2-week training. We do need to adapt culturally for idioms, stories, cultural norms. It's best to avoid clinical terms like depression because those can be stigmatizing and othering. It's better to talk about stress or things like that everybody experience. You have to think through supervision and you have to situate it within a local context. But they didn't have to make a whole lot of adaptations to the individual elements. Like, could you do problem solving? Yes. Could you do behavioral activation, which helps people get active to change your mood? Yes. So I mentioned some of this and wanted to, before I jump into the projects, really talk about the US-based translation. So I don't know how many people know Brianna Woods-Jager's work. She's just down the road at Emory. She was a grad from my program, UW Clinical, and we wrote a grant together for her to do some of the task sharing with me in Kenya. We did not get the grant funded, but we wrote a few papers, and if you know Brianna, she's ridiculously productive, so she did the project anyway, even though NIH did not fund us, and she's used that task shifting and task sharing model for her work in Atlanta with boys and girls clubs, and it's very community driven, it's very community owned and rolled out. In fact, she thought she was going to do a project for Black youth, but focused on trauma, so intimate partner violence, physical abuse, sexual abuse. And you said, we don't want that. We want a treatment that's going to focus on racial trauma. So she shifted the entire project to be responsive to what the youth wanted. And she's using task shifting here, working with the Boys and Girls Clubs to have youth lead a racial trauma intervention for their peers. So I just wanted to highlight her stuff. She's out of town this week, so I don't get to see her. But the task sharing has lots of crossover. Dan Whitaker and I were talking last night because he's been doing a project using task sharing with refugee communities. We should do more of this in the US. We just have some rules that make things harder, but increasingly with the mental health workforce shortage, there's going to be more openings for us to do this because we do not have the capacity to provide care with mental health professionals. So jumping back to the terms, implementation science, and some of our work. So we talked about the intervention of the practice, which is the thing that you care about. So for me, that is trauma-focused CBT. The work in Kenya, it's Pamoja Tunaweza, because trauma-focused CBT is English, and the acronym doesn't make sense in Kiswahili. Pamoja Tunaweza means together we can. This is the paper of the RCT outcomes, and I'll walk you through some of the outcomes. But if you have a thing you care about, you need to find out if it works, right? So that's the effectiveness research. Does the intervention work? So we had a large RCT in Tanzania and Kenya. The reason we were working in Tanzania and Kenya, I'll show you in just a second, they're bordering countries. And if you want to have a model of rolling out care that's going to be locally led, locally delivered, local experts, you're probably going to have more like regional hubs of care. You're not going to maybe have a trainer in every single country, but in countries that share a language, that share some tribal or cultural background, you could have trainers who could work across. So we intentionally were working in Tanzania and Kenya to see what it would be like to have this regional kind of network of trainers and hubs. And we did a bunch of things before starting the RCT. I want to mention that because in global health, especially as a white woman who's American, I'm not Kenyan, it's important that you're not just jumping in and doing work in a context you're not part of, you're not a member of. And so for us, there was a lot of past work where actually people had come to me saying, we have Kenyan folks who want to lead this work, we have Tanzanian folks. What we need is somebody who knows an intervention for youth sadness because they'd been studying how youth were doing with the death of one or both parents. And they did learn things like food scarcity, education needs, but guardians were just saying, I don't know how to help with the kid's sadness, so we need an intervention for that. So we had a pilot study that let us figure out exactly how would the community want the intervention to look. We developed train the trainer models so that we could always be moving towards me not playing the role, given that I don't have a shared identity and I'm not Kenyan, I don't know the context as well. And then we also had a lot of ethnographic qualitative work to gain perspectives and adapt measures, given that everything would be in Kiswahili and local tribal languages. Oops, that's the wrong button. Okay. So I did just want to show you briefly the qualitative ethnographic study. The Johns Hopkins group has developed a procedure called DIME, and I can never remember what all it stands for, but one of the things that it includes is a rapid study that you do that is led, well, let me back up. So I needed to know the research procedures, but it's not a study I could ever lead because I don't speak the language. I'm not in the community. So it was one of my neatest research experiences. I went and had the opportunity to train 30 people in a rapid ethnographic qualitative method. They did all the interviews in Kiswahili. They did all the analysis in Kiswahili. We never translated to English. All I had to do was train everybody in the way to do it. And then it worked out in the room. I did have someone translating for me the discussion so that I could understand where people were going with the analysis. But basically, unyanyasaji means to be maltreated, harmed, not cared for the same way as others. And restituta here is walking people through an example of a term that came up on an interview. Each number is either a guardian or a child. And all these terms are overlapping in meaning or area with unyanyasaji, but unyanyasaji is at the top because that's the best overlapping term. But it's a very cool approach, if you want to check it out, for letting communities ask important questions and analyze the data themselves, because you don't have to have like an Excel spreadsheet. It was just like, okay, I have unyanyasaji on my papers. Who else has something like unyanyasaji in your answers? And all the other interviews were sitting around the room. They'd flip through their papers and be like, oh, I do have it, but they called it, kupigwa. So it's a very cool approach, and it helped us make sure that all of our measures would have the terms that families and kids use to describe their problems. It also showed us, you can imagine in a situation where a parent's died, mental health may not be on people's mind. They may be more focused on food, school fees, things like that. What this study lets you do, because we used a very open-ended question, which is the DIME approach, what are all the problems of children who've lost a parent? Mental health problems are still in the running. And people were really interested in an intervention where people would talk to kids about how they were feeling and doing, which suggests an openness and acceptability potentially of a mental health intervention. So this is some of the work we did leading up to the large trial. So the first study, and I'm going to talk about two of these studies, but the first study in terms of that, what tells us, is it working, the effectiveness study, was this large trial in Tanzania and in Kenya, where we randomized 640 kids aged 7 to 13 to receive trauma-focused CBT in groups. And I'm not going into the interventions in detail because I'm more interested in sharing the strategies, but there's lots of information online and lots of papers on trauma-focused CBT if you want to look it up. So we had developed the intervention and had done the cultural adaptation in a small NIH grant that led into this, plus the qualitative work I was describing to you. And in this treatment, we had a 12-session group, because at the time that was the least they'd let me shrink it, the developers. Then later I was allowed to shrink it to 8. So in the next 2, we kept trying to get it smaller and keeping all the essential things. So we had 20 groups per country. And this training, we were focused mainly on clinical outcomes. So are we seeing that kids get better with the intervention? But we were examining some implementation outcomes. And we were using, Jeff Curran has also written about these type studies that are combined effectiveness and implementation. This was a type 1. So this is just, we delivered the interventions were delivered in schools. This is Dada Susan writing the agenda on the board here. These are cognitive triangles on the right. That's a whole list of feelings. Vabaya is bad, Vazuri is good, Fahara is happy. You see Mawazo, which is thoughts, Hasia is feelings, and Tabia is behavior. So the same cognitive triangle that we would do. You were doing it in English, teaching kids the connection between thoughts, feelings, and behavior. And this is the training to deliver it. So unfortunately, the water bottle is prominent, but you have the pictures you have. So it's not really a picture of a water bottle. What it's a picture of is Dada Leonia and Mama Louie delivering the training and me just sitting there. So this was our first step. And the first time, actually, the developers, they wouldn't let the training happen without me in the room, because I think they're US-based, and I think they felt like I needed to be there. But the team came to the US, because I think in global work, it's important not just that you go to them, but they also come to you. So they came to me at UW. We worked out our training plan, and I met with them in the morning and the afternoon to support them. They delivered all the training to 6 new Tanzanian counselors and 6 new Kenyan counselors. And their learning was from, as you saw at the bottom, from big counselors in the pilot study that we had already done. So these are the Kenyan counselors here. These are the Tanzanian supervisors here, not the Tanzanian counselors. They were supervising their Tanzanian colleagues in person, but to supervise the Kenyan colleagues, they were either meeting with them on Skype. This is one time the bandwidth was good enough to watch part of a video, and then I think it never worked again. Basically, it was all audio questions and some role play. But in this situation, they actually had been able to watch. That's where this picture comes from, is them, they took a screenshot of watching the video. And here they're talking to me. So they were learning a new role. They had been counselors. Now they're trainers and supervisors. They didn't need any help from me on the intervention, really, but how do you train and supervise? So they would supervise the 6 local Tanzanian counselors who were in the office with them and remotely supervise the Kenyan counselors who were in Kenya. And then they would meet with me to talk about the training, any questions they had for the counselors and that sort of thing. So we had kind of like a tiered system. Fast forward to the other projects, they don't need to meet with me anymore because now they are trainers and supervisors in their own right, but we're always kind of like moving people up a level. So you can see a little bit about the kids in the study here, and I always think those tables are good to see, but they're also hard to take in when you're in the middle of a lecture, so I'll just leave it there just a second. But you can see, the kids were obviously in the age range, mostly around 10. Most of our guardians were either the surviving bio parent or a grandmother. Pretty high rates of food scarcity in the Kenyan sites, and I'll talk about that a little bit more. Poor guardian health in the Kenyan sites. These are violin plots of the post-treatment outcomes, and you can see the Cohen's d effect sizes for each. So, and these are at 1 year. So we have the end of treatment outcomes too, but we mainly focused on the 1 year because I don't think it matters that much how you are in the treatment. It really matters how you look a year later if we're going to think about, did this make a difference? So one of the things that I'll point out is the measure that we used, 20 is about the clinical cutoff. So you see for most of these kids, they're below the clinical cutoff, and sometimes in the UC group too, which I'll talk about in just a second. But the TF-CBT group really outperformed usual care in urban Kenya and rural Kenya, but less so in urban Tanzania and rural Tanzania. We were really happy that we'd had 2 countries and that we'd had urban and rural areas, because interventions are very different to deliver and to supervise in urban and rural areas. So that was an essential part of the study, and was really great that we had a sample size large enough to look at the differences, because you see we got some pretty substantial differences. Now, I will point out that the differences in Tanzania, in both Tanzanian sites, it wasn't that the TF-CBT kids didn't improve, it's that everybody improved. So this is just kind of in word summary if you prefer that, but basically overall it was very effective in Kenya, large effects for post-traumatic stress. In urban Tanzania, very small effects, and then no effects in rural Tanzania. So even though I'm mostly focused on task shifting, you get these kind of results. For this talk, I did want to walk you through the results that we got because they're pretty different. So the intervention was most effective in the sites with the most stress. So in urban and rural Kenya, you have worse indicators for guardian health, nearly double traumatic events, much greater food scarcity, more kids in the household. Guardians are, doing more to take care of this kid because they've got more kids they're taking care of. We had expected actually that the outcomes might be worse in Kenya because you're getting remote supervision, right? So this is where I do love research, because there were no issues with the remote supervision. Like, I think the counselors maybe had more autonomy, feeling that they had remote supervisors, but the supervisors didn't sit with them in the office. Tanzania has had a much greater cohesive national identity. Also, none of these come from me. These come from my Kenyan and Tanzanian colleagues who know these things and can share it, and then I'm sharing it with you. Tanzania has had a greater cohesive national identity. They developed a common language. They adopted Kiswahili as a national language right after the end of colonization, when they had their independence. There's been greater conflict in Kenya if you followed any of the elections, usually, or the more recent the riots over the taxing recently. And one of my colleagues, who is Kenyan but lived a lot in Tanzania as well, felt that this greater national identity meant that families in the intervention group, in their communities, especially in the rural areas, were sharing what they learned with other families. And I don't know that that's true. We investigated all the other things like data errors, randomization problems. Sometimes when you get these effects, you don't ever know exactly what happened. but we had a masked coder code all of our reports, and the counselors were instructing, the Tanzanian counselors were instructing them to share more, and the kids talked about sharing with other kids, like learning a skill and practicing it with another kid. So because of these effects, however, and that we simply can't totally explain them, the next project did focus in Kenya. So now I'm going to talk about some implementation research that flowed out of this work and that focused in Kenya, where the intervention seemed to be having an effect. So for implementation research, you're really studying how do we best do this thing that we think might have some benefit for children and adolescents. And there were strategies that we were already using. They're implementation strategies, but again, interventions and implementation go hand in hand. Supervision and training are implementation strategies, but can anyone imagine doing an intervention without training and supervision? So they're really closely linked, but we felt we needed more if we were going to really study where could this be delivered in more usual care settings versus the study setup we had in the last one. So we asked our colleagues who had delivered the intervention, we spent a lot of time in between the two grants just saying, like, where would this live? Like, we know it worked in Kenya, it worked in urban and rural areas, but we were asking ACE Africa, our colleagues there, the NGO, where would it live? And they said, well, you see the ACE Africa logo there. They had done a lot with schools and clubs for children who'd lost a parent or both parents, and they also worked a lot with community health volunteers, which are considered the last mile of health care. So communities have a dispensary or a health facility, but the CHV goes the last mile from the facility to the family's homes. So they said, I think maybe schools, maybe the health sector with CHVs, I'm not sure. And CHVs do about 20 hours of voluntary work a month. Now the government has passed a stipend, so they get a mandatory stipend, which is important because it shouldn't just be voluntary work. But they said, I don't know, it would be one of these. So we said, well, then we should look at both. You wouldn't, because with kids, you don't have to be contained to one system, but we do need to know what would be an enabling context to embed this program within these systems. And it might look different because health and education are different. So that was the next grant. Luckily, NIH was really interested in it. It got funded quickly because it is hard to do this continuous work, as y'all know, if you have long periods between grants. And so we got this stepped wedge randomized controlled trial, again with ACE Africa and with our partners at Duke. And we were really looking at, this time, primarily implementation outcomes. So what did it take to adopt, do the intervention well, that's fidelity, and to sustain this intervention in the two sectors. And then a secondary aim was intervention effectiveness and looking at the cost, because that would be important as the country was thinking about, would we scale in schools or would we scale in health? So for this trial, we knew we probably needed some leadership focus, because if education was going to be delivering it, individual schools were going to deliver it, health facilities leaders were going to have to say this is important. They're going to have to signal leadership, and there was going to need to be some implementation support. But I've never delivered this intervention in a school. I don't work in Kenyan schools. I don't work in Kenyan health facilities, and our partners had not done a mental health intervention in that. So we built a study that would let us learn from early sites and learn the things that would work that were obviously affordable because people had already done them. Because in settings with few resources, you can't just come in with like these high dollar, high intensity things, because if they can't be sustained, then nothing goes on past the study. So, here again, implementation outcomes we were interested in for this trial. So this is just the really pretty figure of the stepped wedge cluster randomized trial. Our kid outcomes were the ones that we took advantage of the stepped wedge cluster randomized trial. And you can see the 2 through 7 kind of march out at kind of a normal distribution, but you see there's a much longer period after sequence 1, and that's because we had the period built in to learn what worked for folks there. So, this is what we were really curious about. This is Bungoma Township, and we were really curious what would folks need to be able to deliver these care without a lot of new resources, because those would not be found. So these were the goals of BASIC. And I'm going to walk you through these because this was some very exciting work that hopefully will lead eventually to this being scaled up. So we knew that there were some supports health and education would need, right? The things I've already talked about, training, supervision, resources. But it probably is a little different in education, where teachers have a full-time job. They have a stipend, so that's great. They're already paid, but they probably need workload adjustment to do it. And the health extension workers, the community health volunteers, they do their work in the community, in people's homes. So they need a space, they may need transport provision, maybe need a little more training, because teachers have a lot of training by the time you teach at a primary or secondary school. You have a more advanced degree. So what we did is we had 10 schools and 10 communities deliver. We did not pick the best ones. We randomly picked 10 and made sure they were distributed across urban and rural areas. And then we looked at both their quantitative measures. We did some qualitative interviews, trying to understand like what they did to deliver, what the barriers were, what the facilitators were, and what potential solutions they thought might be feasible if they hadn't managed to solve a problem. But with more time, often people can solve their problem. And then our goal was to do this case comparison study. We expected that some sites would implement and some wouldn't. Our design had to change because everybody implemented, which is a great outcome, but I was like, what do I do now? And I've already published the study protocol, so I'll tell you about that. And then the plan was to use that learning to support the next 30 schools and 30 communities. Again, building that local community leadership, because we were going to have implementation coaches, which could be called facilitators or implementation support practitioners. That's a new term in the literature, who'd already done it to support the new ones, because then you can just kind of keep that kind of model going. So what we did when the things changed, I talked to Brian Weiner at UW, who's on this grant, and he said, actually, that's a great problem that everybody succeeded. Now you can study different ways they succeeded, or recipes for how they succeeded. And there were lots of different recipes for how people succeeded. So, you know, this was a wonderful learning opportunity, which I'll show you some of what we learned in a minute. And then the goal was to use a community meeting to present the results, what we'd learned, and then be able to build this implementation support coaching. So this is a picture of one of my colleagues presenting the findings of what we had learned to a group of ministry officials, both from health and education, folks who delivered, but also just leaders who hadn't delivered but knew the systems. This is a picture of a small group of community health volunteers talking through what they feel and they had delivered from Moja-Tunawesa, talking through what they heard about the findings and trying to think about, well, what would we need to do to support new sites? And they wrote out plans over time, which I'm going to show you. They were all developed by sectors. There are tables of teachers and education officials and tables of community health volunteers and health officials. And then what you're seeing here is one of the very first coaching visits where they used that support to talk to new community health volunteers who would be delivering in the next stage. So what did we learn? So one of the things we learned is that teachers, more than CHVs, again, what support do different sectors need? They needed a lot of workload adjustment. Only a little more than half got adjustment for the training, so you can bet that was built into the plan the next time to help deputy teachers and head teachers, those are like principals here, make that plan. They needed more adjustment even to deliver the intervention. CHVs didn't need that much adjustment because they had that more flexible work schedule. We also learned, and this was fascinating, I think urban schools had up to 8 ways they did workload adjustment from our qualitative coding. Rural schools had 1. So it was very clear that that coaching, even within sector, would need to be tailored to urban or rural. We also learned a lot about attitudes and passion and what really mattered. So you see both teachers and CHVs were really passionate, talked about persuasive communication from their leaders. And they also, but there were some differences where the CHVs, I think they were so excited about doing this intervention as volunteers in their community who saw these needs and didn't have a full-time job like the teachers. Their passion was a huge driver of their success. But leadership really mattered because counselors were more likely to talk about their own positive attitude when their leaders were positive, passionate, and supported. And that's how we talked about implementation leadership. So I'm going to come back to the non-jargon terms in a second, but this is an implementation science term, implementation science leadership. And we spent a lot of time before presenting these results saying, how do we describe this to our community? And by using the more simplified terms, they were all talking about passionate, supported, and positive Moja-Tunawesa attitudes by the end of the training because they were, the community meeting, because they were using these same terms to communicate. So in that community meeting, what ended up happening is the groups of teachers and community health volunteers built just basically support things that needed to happen when you were getting started, when you were preparing for delivery, when you were implementing, and then for sustainment. Once they got going, they really felt we didn't need both of these meetings, and so that's why it's circled, because from their feedback, we dropped it to just 1. But this was kind of the plan that they did. And these are some of the things that they talked about. These were the core elements that were part of the coaching that were handled. And teachers coach teachers, and CHVs coach CHVs. We used this thing developing like solutions for goals. So if the goal was like workload adjustment, they could come up with different ways to get to that. It was flexible and tailored so that you could come up with what would work for you to accomplish that goal, given the school's differences and CHV differences. And also from some of Prerna's work, we saw that these were the major roles of coaches. And I'll just let you take a look at the quote from one of the teachers about this experience. So basically, the teacher counselors, I think it was really powerful to get coached by a former teacher who'd done exactly what you were doing and knew your setting. Because a teacher really knows how to work in a school in a way that someone who's not a teacher might not know. So the last thing, I'll say on this one, and then I'm just going to touch on a piece of the work in the U.S. just to kind of crosswalk these things. My colleagues from Kenya were invited to be the plenary speakers at a conference in Seattle. They talked about these terms, and there was so much interest in the non-jargon language that we ended up publishing a paper with our non-jargon terms for the implementation science things with some of my faculty colleagues at the University of Nairobi. So that was really fun to put that out there. And I never thought people would want that, but I think we're all hungry for how do you describe these complicated things in ways that everybody can engage and reduces that power differential. So a quick basic update, like where are we now? What happened when CHVs and teachers delivered? So they've done amazing. My statistician literally ran these yesterday. So we're trying with the stepped wedge, it's a very complicated design, but you can see here now, is that a little bit of a lower effect size? Yeah. But scale sometimes has a slightly lower effect size for reach. We were talking about this at the lunch today, like reach matters more than and this is still a pretty big medium effect. And these are teachers delivering to their kids and community health volunteers delivering. This is really promising. And here's how it looks across. We never wanted this to be a head-to-head comparison. So I doubt we'll even publish this, but I wanted to show you they both were effective. Teachers were effective, community health volunteers were effective, and this is a slightly different measure than on the other one because the US developers started charging for the other measure. So we're not using that one anymore because that's not going to help my colleagues in Kenya assess their kids' outcomes. But again, the cutoff is around 20, and so you see it post-intervention. These aren't the 1 year, but they're still doing really well, and they're below the cutoff. So basically, we still have to answer this question. We're analyzing these data now. What does it take? What are the implementation policies and practices we need to be successful? But we're using a method called coincidence analysis, and I just recommend you check that out if you don't know it. It's the new version of qualitative comparative analyses, and it lets you really use what people are saying and doing and compare cases to figure out effectiveness. So I highly recommend it. Now, in 3 quick minutes, I'm going to talk about a similar process in Washington. So we have mental health professionals in Washington, but oftentimes we don't use our leaders within our organizations to do the leadership of interventions. And so that just wanted to show you briefly what we've done here. So we started using our supervisors in community mental health to be trainers along with the faculty who teach the interventions in a statewide funded CBT initiative we have. And in Noah's work, my graduate student, the local trainers who are supervisors did just as well as the university officials. There's one small difference on credibility, but it's not really clinically meaningful, 2.8 versus 4.2 versus 4.5 is not that big of a difference. And the outcomes for clinicians learning were similar. So we don't do any more training that isn't co-led by our community supervisors. And then what we wanted to do is move not just from clinical leadership, but to implementation leadership, in large part informed by the coaching that we had done in Kenya. So in a center grant that I have with Brian Weiner, we've been testing, can we train supervisors to do this same kind of implementation coaching like I just presented to you in Kenya with supervisors and new clinicians. And we're in the middle of that now, or we just finished the RCT. We do some connections at these various points. The pilot was led by me, but again, I want everything to be led by our community members, so the current RCT is led by the supervisors. We have these plans where they can write down what they're going to do to sell it. Again, it's form and function, where the function is to do support, but you can make it however you want it to be. And we've gotten some great data on that's very acceptable. You know, people like the supervision by their supervisors. They attend by their fellow supervisors. They think it's really great. And there's benefits for clinicians. So we have an online program where clinicians track their cases, and we saw differences in that pilot that I led by how much their clinicians engaged with the intervention and delivered. So the last thing I wanted to share with you is that the update on this study, which again is this local leadership, how do you take supervisors who know better than I don't work in community mental health, how to support people. Kenesha Rourke, one of my colleagues, just finished a call with her supervisors last week. We're analyzing the data, but her quote was, participants of the group, so it's supervisors, meeting with Kenesha, who's a supervisor, expressed they enjoyed the collaboration, they found value in sharing their experiences, they were navigating similar challenges, and the combination of their expertise allowed them to provide constructive feedback and encourage diverse considerations. Although the collective experience of the group was extensive, because these are supervisors, they all have a lot of experience, I was still able to contribute a fresh perspective and additional support with the coaching program. So her recommendation was the state should pay for this. So we'll see if the state does after we get the evidence. But, you know, it's fun in the work that we do to learn things globally and then be like, why are we not doing this here? And then to kind of have what NIH is calling reciprocal learning across the context. And most of my thanks are to the folks who did the BASIC project, which is the largest list of my collaborators. These are my graduate students who are also big collaborators and so are in a lot of that work. And thank you very much for having me today.